Hi, I'm Dr. David Cotter, a board-certified dermatologist practicing in Las Vegas at Las Vegas Dermatology, where I also serve as the director of clinical research. We're here at RAD today, and I just finished up our session of Medical Crossfire, wherein my colleagues and I each took a disease class, and we talked about the therapeutic landscape for atopic dermatitis, with one person taking IL-13 inhibitors, another with IL-31, another with IL-4, IL-13 inhibitors, and I took JAK inhibitors. And the idea was to cover the entire therapeutic landscape and weave in difficult patient cases and pearls as to why you might start one medication over another and how to manage those patients in the long run. We had a fun theme this year. Our leader, Nick Fury, aka Butic, who headed the session, although he's a self-proclaimed Thor, and he really is, because that guy brings the hammer when it comes to leading the charge in science and dermatology, came up with this idea to have a Marvel Avengers theme. So we were the Derm Avengers this year. I was the Hulk, for reasons that I'm not entirely proud of, but let me just put it this way. You won't like me when I'm angry, and you're going to make me angry if you use steroids to treat atopic dermatitis, which is actually recommended against in the atopic dermatitis guidelines. What I focused my talk on was the rapid and robust nature of JAK inhibitors, what that offers and means for our patients with atopic dermatitis. If you think you need prednisone to get someone under control quick, just say no. Drugs are bad, particularly when they're steroids. Reach for a JAK inhibitor instead. That was the focus of my talk, but arguably there were great data, great reasons why you might use a biologic like dupilumab, lebrikizumab, tralokinumab, or nemolizumab, and a need for a very lively discussion as to why you might pick one drug or another in a different patient type. In my session today, we focused on how to manage JAKs with a couple of pearls. Number one, get used to your elevator pitch, and it always starts with the value proposition. I'm picking this medicine for you, or we're choosing this medicine together because it works very rapidly and very effectively. But there's a couple things that we need to sort out. I'll ask my patients some simple questions about whether or not they've had a blood clot, a cancer, or a heart attack, and I'll tell them we're going to check some baseline labs to make sure you're otherwise a good candidate. And we have a JAK start panel. That's pearl number one. Have that panel ready so your medical assistant knows if you're thinking about a JAK to get that blood work panel ready now. And on the panel, you check the CBC with differential, a complete metabolic panel, fasting lipids, TB, Hep B, Hep C. You might ask the patient if they could be pregnant, check it if it's appropriate. You might ask them if they could have HIV and check it if it's appropriate. But I leave those up to the patient and my discussion. I also recommend all age-appropriate vaccines, particularly giving the shingles vaccine, if not before they start the medicine shortly into their course. The second thing is managing complications, and the best way to do that is to prevent complications. And with JAK inhibitors, that starts with getting the shingles vaccine and also being aware of those common side effect, which is JAK. Fortunately, in dermatology, we know how to treat acne. The patients are already in the correct space. But there are those side effects that keep us all up at night, the ones that are related to the boxed warning, the FDA, venous thromboembolism, major adverse cardiovascular events, or MACE, things like heart attacks and stroke, cancers other than non-melanoma skin cancer, and of course, serious infection. The reality is we look at large data sets, multi-year safety studies, we're talking about over 9,000 patient years of experience. We just don't see extraordinarily high rates of those scary events in patients on JAK inhibitors when they're used to treat atopic dermatitis. They're actually very similar to what you'd expect for background rates. And something I talk with my patients about, I counsel them, I let them know that I know what the internet search or the AI platform they use says, and I'm still not concerned about that for them. And I think this might be the best medicine for them. Again, getting back to that value proposition of a rapid and robust response. I'm excited about the future in atopic dermatitis because even when we look at the best medicines with objectively and statistically head-to-head studies and network meta-analyses are JAK inhibitors, they don't get 100% of patients across the finish line. There's still a lot of room for new emerging therapeutics. Dr. Butic talked a lot today about bi and tri-specific antibodies that may provide additional ways to get patients under better control, sometimes quicker control earlier, and better durability later, depending on how you mix and match your monoclonal antibodies. Beyond that, I'm interested in personalized medicine in dermatology, meaning the right treatment for the right patient at the right time, which should be anytime you're reaching for a drug, you want it to be the right one. We have some emerging data in the gene expression profiling realm where we can actually begin to predict which classes of medicine a patient is more likely to respond to, whether they might truly need a JAK inhibitor or they'd be okay with a biologic or a JAK. And as that continues to develop further, I hope that we'll develop granular level of detail, whether it's gene expression profiling or other biomarkers that can predict which biologic I should reach for or which JAK inhibitor specifically at the drug level to help my patient with atopic dermatitis. We're always working on exciting things in Las Vegas, but there's nothing that I need to promote personally, but I will promote something from an advocacy level for all of the dermatologists, dermatology PAs, and dermatology NPs that might be listening. There's one threat to all of us in medicine and to our patients, and that's the Medicare physician fee schedule. If you do not reform the way physicians, PAs, and NPs are compensated to do their job, offices will close and patients will lose access to care. You might not understand what your professional organizations do or don't do for you, but at least for the AED, a major arm of the AED's advocacy and legislative task force is fighting the good fight to fix the fee schedule so we can all continue to afford to care for our patients.